Good morning, everyone. Welcome to the session on multidisciplinary approach in the management of congenital lens subluxation. So, what made me think to choose this topic was many of times I happen to see kids who come little late with the complications of congenital lens subluxation. Most of us tend to treat just to look at the refractive correction alone. So these kids actually have years to go before they develop any complications. So first, let me welcome the speakers. Dr. Meena CK from Little Flower Hospital. She is a pediatric ophthalmologist. Myself, I am also from Little Flower Hospital. I am a vitreoretinal surgeon. And Professor Prafula Kumar, he is from AIMS, Delhi. He is basically cornea and refractive surgeon. So he would be discussing with us a new technique to deal with this situation. Dr. Roni won't be able to make up for this session. He has given a recorded talk, so if time permits, we will play that. So first, let me welcome Dr. Meena CK. She's a well-known pediatric ophthalmologist at Little Flower Hospital, a very good surgeon, compassionate doctor, a pediatric ophthalmologist. So welcome her for the first talk, pediatric ophthalmologist perspective in dealing with congenital lens subluxation.
Full screen ആക്കാം. Just slide ചെയ്താൽ മതിയോ? Full screen ആക്കല്ലേ? Okay, good morning everyone. At the outset, I would like to thank Divya and the KSOS organizers for this opportunity. And I'll be speaking on a pediatric ophthalmologist perspective on the management of congenital lens subluxation, and it's purely my practical experience that I will be discussing. So coming to whenever a child or a young adult, sometimes they come as young adult, they come to us with congenital dislocation, subluxation of the lens. The few things that runs in our mind are what could be the cause for this, and a detailed family history, because many of these runs in families, and the current situation is the thing of the present that we are more bothered about. And if we need any investigations to be done, and the first aim will be for a conservative management, and ultimate will be a surgical one. So coming to the causes, we know there are a number of causes for congenital subluxation, but in my experience, more we have seen of Marfan syndrome. Maybe it is easier to diagnose. Then you have the simple primary ectopia lentis, and the other situations like homocystinuria, Ehlers-Danlos syndrome, we do see, but it is little more rarer. Now coming to a detailed family history is extremely important, because it is very common to have a mother or a father with the similar physical characteristics, which helps you in the diagnosis, and also you should ask for the consanguinity. So the investigation part, do you need to investigate all the cases? It is not a must that you have to investigate if you have a proper diagnosis. And clinical picture itself gives you a clue. You see a tall mother or father accompany a tall child, then itself you can make a diagnosis. And a detailed systemic evaluation is mainly for academic purpose, and also rule out comorbidities when you are intervening these children. And also a genetic screening if they are planning for extension of their family. So we are more bothered about the current situation, and what can you do in the current situation? That is mainly a refractive status is what decides the vision of the child. So vision of the child is very important, and many of them do come late, especially when it is unilateral. So you can manage them conservatively if there is acceptable vision with correction, and it could be a spectacle or a contact lenses. And the intraocular pressure status is also important, because this abnormal position of the lens can cause an increase in intraocular pressure, and you need a detailed fundus evaluation also, because many a times peripheral fundus examination can be difficult, and there will be associated high myopia in many of these cases, and a poor cooperation of the child and undilating pupil is also common in congenital subluxations. So what are the indications for surgical intervention? So lens-induced glaucoma, dislocated lens, or Morgagnon cataract, it is little rare, and lens-induced uveitis. Commonly what we do are, we intervene mainly when there is a visual acuity is not improving with refractive correction, and the remaining part goes to the retinal surgeon. We don't have to do anything, we just have to refer the patient to the retinal specialist. So in my experience, it was mainly a visual acuity loss and not able to correct them, give them refractive correction was the main indication for surgery. Now coming to the significant subluxations where the vision is compromised as well as the binocularity is lost. Like here you can see this child came at in 2010. We have a 15-year follow-up now. Had a subluxation in the right eye and the vision was only half by 60. Left eye a mild subluxation, the vision was okay. And you can see it underwent a lens removal followed by a iris claw later, and almost 15 years of follow-up the child has come with a 624 vision in the right eye and 6 in the left eye, which is decent vision in such a situation. So what are the things that you can do when you have a significant subluxation? An anterior segment surgeon will always be interested to keep the bag of the bag intact if possible, and also not to disturb the vitreous much. That would be our aim, but it may not be possible in all cases. This case you can see it is a significant subluxation, but still I was thinking I always try to do a rhexis in all these cases, and I could get away with the rhexis because the rest of the zonules were quite strong. And the rhexis should be of adequate size, and only then you can put in an IOL. So there's no point in putting a very small rhexis, and it should not reach the edges also. So here you don't know the size of the lens, so putting in a CTR is not safe in such cases. So you can get away with CT segments, and also you can do the aspiration of the lens from the bag itself. Try not to put it into the vitreous, try not to disturb the vitreous. That is what you should do. And here even after aspiration you can see the bag is more or less stable, and I have not gone for a CTR because I'm not sure whether the bag is of adequate size. So these CT segments are very good ones, like you get it in 9mm and 6mm size, and you can fixate those bags. And next problem is which IOL to put. That is a big issue in these cases, because IOL power calculation may not be correct, especially when you do IOL power in a subluxated lens. Axial length may not be correct, and you can't put in just guessing and putting an IOL is also not safe. So it will be ideal you wait for a while, do the next procedure in 1 week itself before the bag collapses. And here you can see the child underwent. You have to deal with the posterior capsule also. So after 2 days I did a secondary posterior capsular rhexis, and the next day we checked the IOL power using the IOL master, and we could get the power, and a secondary rhexis is being done here. Usually we do a PPC. So here you can see the segment there, and IOL was put in the bag. I put a 3-piece IOL. There's no question of putting it in the sulcus in such cases. So 3-piece IOL, the main aim is so that the haptics are, it's easier to deal with the haptics even if the bag is a little small. And also it would be ideal to see the fundus in the OT itself, to see the periphery of the fundus, and if any treatable lesions are there, it's ideal, it would be better to treat them before you put in the IOL. And child has been doing well for almost 1 year, more than 1 year now follow-up. But in cases like this, you can see the lens is just hanging from a stalk. So there's no point in, and there is also microspherophakia. You cannot think of putting a segment or ring or anything in these cases. It's just to remove the IOL in such cases. You can't have too much of expectations. So here it just comes out easily. Only sometimes these zonules can be strong, but here you can see it is easily coming out. And now you can see it's a small lens, and you can think of putting in a secondary IOL later. So what are the secondary intraocular lens options you have? So iris claw IOLs are actually, it is a little blind procedure, but still it is a very easy and not easy, but it's less time consuming procedure, and many of them do well, but you're not sure in all cases. Like here you can see that IOL is introduced in the anterior chamber, and the pupil has to be of adequate size. Only then you can think of an iris claw lens, and you are enclavating the haptics. But I used to get very good results, but to once bitten, twice shy. I had 2 cases of Marfan's who develop an atrophy of the iris at the enclavated site and dislodging of one haptic, and that is a very traumatic experience. So after that I am quite shaky, and I don't feel like putting iris claw in children. So nowadays I plan to do scleral fixation in all these cases. Now coming to the sutured scleral fixation IOLs, which we were practicing earlier before we had these three-piece glued IOLs. So sutured scleral fixation IOLs we have been doing quite long back. Now we are not doing, so I don't have the videos of that. And you can see this is a child of 10 years of follow-up, doing well, but you can see so much of pseudo-phacodonosis appears here. You can see as the child moves sideways, an optic capture is happening, but stable vision is there, but still it is also a blind procedure where you are not seeing what is happening to the sutures, and you have that special scleral lenses, scleral fixation lenses, which we were using earlier. So now, it is mainly the glued IOL, and glued IOL gives really good results, and also the whole procedure is little more easier, and stability of the lens is really good, like not much of pseudo-phacodonosis. Only thing, the procedure you have to be very meticulous in the proper centration of the IOL, because little bit of decentration can be difficult, and any vitreous has to be tackled. It is more difficult in vitrectomized eyes. When you are just doing a lens removal and putting it as a secondary procedure, it's much more easier. And proper centration is very important. I still do with a scleral flap, which I feel is more comfortable for me and gives a proper closure of these exposed haptics. So the greatest issue in glued IOLs is you are externalizing your haptics, so you have to be very careful with that. You have to counsel the parents as to any problem, any pain, you have to come, because you never know whether they'll have eye rubbing, trauma, and all those conditions. So here a three-piece lens is being introduced, and you can see the engripping forceps is used to retrieve the leading haptic, and these small tips you get from your retina colleagues, like this I got from Divya, how to put in a small scleral piece so that it won't go back, and you don't need an assistant to hold the haptic when you are putting in the trailing haptic. And now I'm just introducing the trailing haptic, and it has to be exactly diagonally opposite, otherwise your centration won't be good. And gluing the wound as well as the conjunctiva gives so much comfort post-operatively. So this is one procedure I've been sticking to for the past few years now, because the results are quite good. Only thing, you have to be very careful in vitrectomized eyes that bleed should not go into the vitreous cavity, because once bleed goes, secondary glaucoma and issues are really painful, especially in a child. Examination of intraocular pressure, all these things are very difficult. So have a good retina follow-up as well as a pre-retina evaluation before you go for all these procedures, because all these are done as lifelong procedures and we can't be changing all these IOLs. So what next is the post-operative care. That is more important. Especially they come to the pediatric part, like wound and IOL related follow-ups, which is extremely important. Like you should always be sure that the haptic is not exposed, and you can have myopic shifts in these children and do recurrent refractions and give glasses. And any acute emergencies, always counsel the parents that if you have any pain or anything, just come to us, and immediately you have to intervene in such cases. So thank you for your patient viewing.
Thank you, Dr. Meena, for that wonderful talk. So I think in your hands now, your preferred technique for the IOL is glued IOLs. Yes. Than the iris fixator.
Iris claw, I told you, no, I'm afraid of that atrophy that can happen later, which is not in your control. You can do an iris claw, but if they come after 2 years with such problems, it is really painful. So I prefer the glued IOLs.
And I think the important message what she mentioned was like, because when their vision becomes normal, the children actually tend to lose follow-up. So when they lost to follow-up, and then when they develop something like a haptic exposure, the risk of endophthalmitis and all those things are very high. So it is very important to insist on that follow-up thing. Yes, sir.
Thank you. That was a nice lecture.
Thank you.
And few not questions, but just what's your take on what are the distance at which you make the cochlear flap? Because in adult versus pediatric patients, the past one may be different.
Yeah.
So that is one. Second, you said put some scleral pads so that the other haptic doesn't go in, because
Yeah.
in all these kids, that is a very scary thing because eye globe suddenly collapses and haptic goes in. That is the second query. How you do that? And third, is there any cutoff for your scleral fixated IOLs?
The young-
Because at RP center, we used to do it even in 2 year, 3 year kids. But now we have realized in this case, the sclera is very thin. So now we wait till at least 5 to 6 years, then only we go for scleral fixated IOLs. And last, you are perfect. Even I don't do a iris fixated IOL because all this ectopia lentis patient, they have dilator muscle atrophy. So by enclaving, you may further aggravate that. So that's a very valid point that you made.
So earlier years you're a little ignorant, no, but you'll be more brave. But when you get patients coming back to you, only then you start thinking about it. So I use the guarded blade. That was one thing that gives you some confidence that it won't go too deep. And only 0.5 to just beyond the gray area, I put in the needle. And the flap, usually I don't have a problem with the flap. The centration is very important. It has to be diagonally opposite. That is more important. And at the younger stage, I used to do it at 3 years and all earlier. But as you said, now I'm putting a cutoff of 4 to 5 years. And many a time unilateral cases come to you late also. So usually the cutoff is now like 4 to 5 years. And most of them do well. That's all. Thank you.
I think the age, because the pass planner usually developed by 6 to 7 years. So if you're doing like a secondary procedure, preferably by around 6 or something would be the ideal age. So,
next speaker is Dr. Divya Balakrishnan. Divya needs no introduction, and she is the pediatric retinal surgeon with great experience, trained at Little LV Prasad Eye Hospital, where she was working as a consultant as well. And she's one of the best in pediatric retina, and such a piece for us once she has joined our institute. Over to you, Divya.
Thank you, Dr. Meena, for that introduction, and thanks KSOS for giving us this opportunity. So I'll be talking about, because ectopia lens always you will think in terms of only lens. So we need to look something beyond that. So that is why I thought like the genetics and the systemic thing is also very important in these patients. And ectopia lenses, when we think in some conditions, the lens is of normal depth, and it is subluxated or dislocated depending upon the extent of the zonules, which is weak. But one more thing which we need to look is the thickness of the lens and the whether it is a very small lens. So that is microspherophakia. So we need to differentiate these, and mainly we look at these because of the high refractive error, that is the high minus power which the patient might be having, or because of the astigmatism. And then the second thing would be the secondary glaucoma, or sometimes the retinal problems like retinal detachment. So as I mentioned, the normal lens subluxation and the microspherophakia, we need to differentiate when you see these kids. And the normal lens subluxation can happen in conditions like Marfan's, even homocystinuria, as Dr. Meena has already mentioned, and the complications which might occur because of the progressive subluxation. But in microspherophakia, we need to be very careful because the lens diameter as such is less, the thickness of the lens is more, and because of these, there is an increased chance that it can cause a recurrent pupillary block. So, and the refractive error these kids would be having would be on the higher side. So we need to initially differentiate between these two entities when you see these kids. And why genetic? She has already mentioned the systemic implications of these having ectopia lentis. So some of these are like associated with systemic, and some genetic mutations will have only isolated ocular pathology. So something like FBN1 mutation will be having usually associated with Marfan, so sometimes rarely Weil's Marchesani, and isolated. And this one is the most common form of familial cases. So this is the importance of genetics, especially when you don't have a diagnosis. So ectopia lentis, you need to be differentiate whether it is a purely ocular or whether it is associated with systemic manifestations. So that is how you differentiate whether it is a syndromic or isolated. In syndromic, usually we come across is the commonest one is Marfan, but very careful when you have to diagnose something like a Weil Marchesani, because these are associated with microspherophakia and very high risk of pupillary block glaucoma. And another one is Cohen syndrome. So all these have systemic features. If you pick up the systemic features, it is very important to diagnose what could be the prognosis and what should be the follow-up of these kids. Very commonly come across is the Marfan's one, which everyone knows that because of the tall stature and the cardiovascular risk which is associated with this. Homocystinuria, you have to be very careful, especially when you take these kids for surgery under GA, because they have very high risk of thromboembolic episodes, so the hydration. The kids should not be overnight fasting or that thing we have to be very important keep in mind. The other causes could be ectopia lendis, pupillosticular syndrome, sulfite oxidase deficiency. So, and another one which, in fact, I had some patients who had operated earlier. Later, I came to know those who were at Trabowsi syndrome. The important aspects of this is like a facial dysmorphism, lens subluxation, anterior segment abnormalities. And one more very important thing which I had seen in patients and which I did not know earlier was they would have something like a self-forming blebs. So we always ask the history whether there was a history of TRAB, but no, because their sclera is very thin, they spontaneously forms these bleb. So when you do such procedures in these eyes, you have to be very careful, especially when you plan for any scleral procedures, because the risk of thinning is there. And they have cardio and pulmonary complications. So very important is that first you ask a comprehensive family history when you see these kids, anyone in the family has been affected, then check it the systemic history, whether it has any cardiac issues, pulmonary issues, any skeletal issues regarding this, and then you need like a multidisciplinary approach to these kids, looking at the cardiologist, then pediatric ophthalmologist, orthopedician, etc. So now you understand that just a subluxation is not just subluxation, but it is a multi-system involvement and you need that multidisciplinary care. So coming to the examination, a detailed functional testing, very important is that we need to see with this high power how much the kid is able to see, whether he is nearing or he is able to read near things, whether his life is getting disturbed because of this high power what the kid is using. And then slit lamp examination, especially to look whether it is a microspherophakia or a normal thickness of the lens. And always, whenever possible, try to do a gonioscopy, because some of these kids might be having an basically abnormal angle pathology, or might be having, because of the repeated pupillary block, it might have caused an angle closure. So these things carry very important value when you plan for surgical management in this. And then screen for any of these, because in kids that gonioscopy would be difficult. So if any time you are taking the kid for a GA examination, then do for that. Then advise on family screening. So I mentioned the systemic complications. So the systemic investigations needed in these kids should pertain to all those system involvement. And genetic testing, as I mentioned, there are specific genes to pick up these mutations, and whenever you have a diagnostic dilemma, then go for a whole genome sequencing to pick up anything we are missing out on. So do we need a genetic testing in all these kids? As when you have an early onset, any family members are affected, and when there is any associated systemic features, or where you are confused whether the diagnosis is due to because of this entity, and also in following up these kids and family counseling. So these are the areas where you need genetic testing. And why it is important? Because you will know that inheritance pattern. It is very important in assessing the recurrence of this in the siblings or the newborn when they are planning the family, and the psychosocial support and the family screening. So how do you follow up and monitor this one? When you see these kids at the initial assessment, a baseline visual acuity, the lens position, intraocular pressure, and systemic screening. And you do it 3 to 6 months. If everything is stable for a period of 6 to 12 months, then you increase the frequency of, reduce the frequency of the follow-up. Every visit you have to track the progression of the lens subluxation, intraocular pressure measurement, and the refractive error which is happening. If it is progressing very fast, you need to see them every 1 to 3 months, and then you need to decide when you have to plan for the intervention. So, and including that, along with that, the systemic surveillance. So it just an ectopia lendis, now it has opened up, like it is a diagnostic window where you get a chance. It is a very important clinical indicator of the underlying systemic genetic disorder, and early intervention actually would help us to provide an early better life for these kids, and also at tackling the systemic complications, and for genetic counseling also. So the integration of genetics with clinical ophthalmology transforms the congenital lens subluxation from an isolated ocular finding into a getaway for comprehensive life-saving patient care. Thank you.
Thank you, Divya, for that wonderful talk. How often do you send these patients for genetic
See,
screening?
in our scenario, the problem is that because it is little expensive, so many of them won't agree for that. But especially when you see the siblings or sometimes the very strong family history, then it is always better to send them. So sometimes you see the brother, sister are affected in the same family. When you ask the history, the father or mother also would have come affected with the same thing. So then it is better to have a genetic, especially in some syndromic, as Trabosius syndrome and all those, and even Marfan's. Marfan's usually you will be able to pick it up because of the clinical feature itself, but other, it is very important.
Thank you, Divya. Our next speaker is Dr. Prafulla K. Maharana. He will be speaking on ILLA in ectopic lentis, and he is currently the additional professor at RP Center, All India Institute of Medical Sciences, New Delhi, and his specialty is cornea, cataract, and refractive services. And he is the current secretary of DOS, and there are many books authored by him, mainly for the PGs. Welcome, Dr. Prafulla, and you'll be speaking on ILLA.
Thank you so much, ma'am. And your PPT has made my life little easier. So I'll focus on one technique that we have described to deal with cases of extreme ectopial lentis. Extreme, what I mean to say, when there's dislocation, lens is dislocated to enter a chamber. So ectopial lentis, ma'am has already highlighted all the causes for that, but common causes that we encounter is trauma, Marfan syndrome, homocystinuria, wheel marches hernia, Noonan and microspherophobia. So these are few examples. RP center is basically a referral center. We tend to get such cases. You can see this is a 40-year lady with a lens in entry chamber, and this was patients with entry dislocation of lens. You can see the edge and with corneal scarring because it was present since a long time. Here the corneal edema was already there. So in all these patients, why one should intervene is because if you don't intervene, there will be persistent corneal edema, the endothelium will fail, and you may land up in intractable glaucoma. So this is another case. You can see even the vascularization has started because of this lens being in entry chamber for a prolonged period of time. So this is a microscope integrated OCT just to show you how this lenses get stuck to your endothelium, and you can see there is fibrosis here. So if you leave these lenses for a long time, there will descent scar, and that will not resolve even when you remove the lens. So what are the technique that has been described? Earlier days people used to do ICC, but nowadays nobody does that. But there are some other procedures that are quite effective, like lensectomy. You do with go with the limbal route and take it out with the intravitreous cutter. Phacoemulsion with SFIL. Little, if the patients are little bit elderly, then you can go with phaco with SFIL. In the bag bimanual aspiration and intravitrectomy. This is what we have little bit modified this technique. Then Congenital also same endocapsular aspiration with ACOL with a vitrectomy cutter. So what we did in this technique, which we published in the journal I, is instead of using cutter, we use a bimanual irrigation aspiration, and there are little modifications so that the surgery becomes easy. So we have published this technique as a surgical technique in IGO also. You can go and read that article. The basic steps of this technique involves, you can see this is entry dislocated lens in entry chamber. So what you do initially, as you can see, I'll inject some viscoelastic so that this gets free from the posterior surface of endothelium. So make a incision, MBR cut, and if you notice here carefully what I did, with this entry I directly entered into the equator of the lens. So my MBR put and capsulotomy, each with single incision only. So I directly entered into the capsule. So that is by capsulotomy, one capsulotomy. The same on the other side. Go in and enter into the equator. So we have created two capsulotomy near the equator. Then yes, I'll inject some viscoelastic. You can see the tip of my cannula. This is a microscope integrated OCT. Continuous monitoring is possible, but the capsule was stuck. So what then the next step is you go into bimanual irrigation aspiration. You can see these are the two capsulotomy I had made. So through one port I'll go with my irrigation. The other is aspiration probe. And if you notice carefully, both the probes are inside the lens. That's why the terminology intralenticular lens aspiration. And you have to keep your irrigation pressure or bottle height for previous machine, little on lower side, so that it doesn't lead to extension of this tear. Now slowly you can remove the entire lens matter. Now why we are doing this? Earlier people used to go in and cut it with a vitrectomy cutter. So this is because suppose you cut the posterior capsule and lens matter are still there, then the lens matter may drop into the vitreous cavity. It may be small, but it may induce a lot of inflammation postoperatively. And second, if you are pulling with cutter, then inadvertently you may pull this entire capsule which is stuck to your endothelium, and that may damage your endothelium further. So in this technique, what we did, we went in with your bimanual irrigation aspiration. Once I am sure that my entire lens matter has been removed, then I'll use a intravitreal forceps to gradually peel. You can see this, I am gradually peeling the capsule from the endothelium. And is it going to damage? Maybe, but you can see this fibrosis area. Okay, so whenever there is fibrosis, there is a potential gap or space or layer forms. If you apply gent pressure, then there won't be that much damage to the endothelium. Then yes, you have to do PI in this patient. And in this in such patients, as I was discussing, I usually avoid doing a simultaneous iris restricted SFIL, because the sclera is thin. This a lot of this ectopia lentis patient, they have blue sclera. And second, the pars plana, I am not sure how far is it, so I will wait till 6 to 7 years of age, then I will go for a SFIL. But initially when I did, what I realized, when my fellows were trying to do, once they are out of the lens, then they used to find it difficult to know where exactly those MBR entries were made on the equator. So we did little modification. If you look carefully, so I went in and I injected little bit dye here. See this trypan blue, not in the intracameral but inside the lens, so that there is a blue staining here. And if accidentally I come out when I am going in again, then I can know, yes, this is the capsulotomy that I had made. Other than that, all the rest of the technique are same. Here again you can see it is there. It's a microspheropecia case. There was persistent synecdoche. The IP was very high. So in this patient again we did the same technique. So these are the key points which I have already highlighted. Okay, trypan blue is a must. Once you do the capsulotomy, you can do gentle hydrodelineation, and bimanual is preferred, not cutter. And once everything is done, first take out the entire capsule and then do the limited intravitrectomy. If you have MIOCT, it helps you in knowing all the steps, but if you don't have, it's not an essential thing. You can still manage such patients. So we have published this 8 patients with this syndrome. You can see homocystinuria, microspheropecia. These are the common ailments, and the median age of the patients were 10 years, because one patient was 35, the median become 10 years. 10 I had corneal lenticular touch with corneal edema, 2 had raised IOP presentation. But the outcome was okay for us, because only one of the patient, he went to endothelial decompensation and subsequently dissect. This is, if you see this image, you can see this sterile thinning blue slider. That's why I normally avoid doing a SFL simultaneously. So why it is important? So there are no intra complication, okay, and this intralenticular manipulation prevents any vitreous prolapse. If you do a cutter with a if you use a cutter, what will happen? The fluid will go into posterior cavity, vitreous will get hydrated, and more vitreous come, okay. And accidentally, if you catch all the iris, you can damage the iris also. In our series, in all patients, there was a significant improvement in the visual acuity. 3 patients have raised IOP and they could be managed with medical management, except one patient. In that, I think our glaucoma team did a trap. So 5 eyes developed central descemet scar, but you can see such scar. But over a period of time, what we realized, this scar become little lesser denser and area wise also small. So they could be rehabilitated with spectacles only. So this was one case of pre-op, you can see, and then we did interlenticular lens aspiration with a PI and post-op. This is the post-op picture, 3 months. This is another patient. So why intralenticular lens aspiration? Because it gives you a controlled removal of lens matter. Whatever earlier technique, they were also effective. They were not bad technique, But with ILLA, it's a very controlled maneuver, and it's a closed chamber where whatever you are doing within the lens. So it avoids a lot of complications, right? Similar technique I have already showed you in that table. They use cutter, but in this we use bimanual irrigation aspiration. And as ma'am introduced, I am currently the secretary of Delhi Ophthalmological Society. Our annual conference is 24 to 26 April 2026. You all can join us. We will do it at Bharat Mandapam. The venue where G20 meet was there. And this is my personal request. I am contesting for member North Zone ARC, and please support me. And these are my books. I think most of students know me because of these books only. So thank you for giving it such a huge response. Thank you.
Thank you, sir, for that wonderful talk and introducing a new technique which we were not like really doing or aware of. And once again, thank you so much for agreeing for this, giving a talk for this IC.
Thank you so much. Actually, what happens, you keep on doing a lot of things without realizing this may be useful to others also. This technique I was doing when I was a senior resident at RP Center. But when I became faculty, then I realized that nobody has published it, so we published that technique. Even you people must be doing a lot of things which you will see, which you will feel is very common. But people doesn't know that this is also a useful technique. So you should always try to publish.
Thank you. And does this technique actually reduce the chances of the corneal decompensation by any chance? Or
Yes, because your lens matter, everything, all the maneuver is inside the capsule, within the capsule. Okay, so no, when you are doing surgery in this patient, the interchamber space is less. So your instrument has a tendency to hit the endothelium if you are not that experienced. Okay, so but if you are doing within the lens, even if your instrument hits the endothelium, it will be the intercapsule that will be there between your endothelium and the probe. So again, that reduces the chances of endothelial trauma.
Can you do it as a dry tap without the saline?
You can do that, but in that case you'll have to have a good assistant who keeps on injecting viscoelastic into the interchamber, because after removing say 30% of the lens matter, the chamber will collapse. So you have to reform your interchamber continuously.
I usually do it as a dry tap with visco and a cortical aspiration.
Yeah, as I said, you
Because
have to use continuous visco.
It's very easy to remove, no, all these lens matter. Okay, thank you very much.
Thank you so much.
The next speaker again is Dr. Divya, and she'll now be speaking on vitreoretinal interventions in ectopia lenses.
so now we have seen the anterior segment management for subluxated lenses. So now when a VR person should intervene. So when there is a complete subluxation into the vitreous cavity, obviously a VR person only should intervene. And some cases when there is, especially in microspherophakia, when the lens is like kind of little unstable and not sure while doing the surgery, it might go posterior, or somebody is not comfortable in putting an IOL in the same sitting. So in those cases, and so anywhere when there is an indication for surgery, and especially when it is quite posterior, then a VR person should intervene. So the options is like it is a pars plana route, which is a lensectomy, and some cases we even tend to do from an anterior route, especially if the lens is quite anterior, and especially in syndromes like Trabulsi, where the risk of scleral thinning and exposure would be more, and the other techniques have already been mentioned. And whenever there is an associated retinal detachment or anything, then again a VR approach is needed. So IOL option already has been mentioned. And as I mentioned about the age, the IOL preferably when you are intervening to put in the same sitting when at least the child is above 5 years of age. I have put the youngest age which I put was 3.5 years in a child with the bilateral subluxation. That was siblings, actually both the siblings, but I would recommend that at least 5 years of age. So I'll just discuss couple of cases so that the importance of why to intervene and manage these cases. So this was a 6-year-old girl who had presented initially at 2010. And that time her vision was 20/50 and both eyes with a -10 in right eye and -8 in the left eye. So this is a timeline of how that kid has gone. So that time, 2010, actually the IOP was controlled with 2 medications, and then on follow-up the IOP was on borderline. They kept on increasing the number of AGMs, and then in 2012, the IOP was still not controlling with the maximum medication. So then, finally in 2015, the cup disc ratio kept on increasing from 0.3 to 0.7 with maximum medication. The IOP was 22 and 28 in the left eye. Then decided that, okay, the child can be taken up for trabeculectomy first. So the child underwent trab with MMC in the left eye. And on 2 weeks follow-up, the child gave a trivial history of trauma, and this was like the iris had prolapsed into the ostium, and it was blocked, and the IOP had gone high. So then this kid was sent to us for a vitrectomy. So then this is a surgical video where the child underwent. So those times I used to do like for clear lens extraction, subscleral sclerotomy lensectomy. Means like I never used to make a separate port for a vitrectomy. So because this was glued IOL, we exteriorized the haptic through the same port where under the flap where you exteriorize the IOL. So through the same port I used to do the lensectomy and vitrectomy. So only 2 ports with an AC maintainer. So this is how the lensectomy was completed, and in all these cases I do a complete vitrectomy, and any areas of lattice degeneration or any weakness, then I do a barrage laser also in these kids because they need a long year of follow-up. And so this was an initial glued IOL technique which I used to do these 4 kids. So after this, the right eye, because again it was on maximum medication and the cup disc ratio was increasing, so so for the left eye initial trab was done, and then when it was not controlled, it was sent for vitrectomy. So now for the right eye they sent in the beginning itself to us for a vitrectomy and glued IOL. So I did a pars plana lensectomy, vitrectomy and glued IOL. So now IOP progression over the time, you can see post surgery it has come down, and now the child is on only 2 medications, and this is the cup disc ratio progression. So till the time of surgery it was like increasing to up to 0.7, and after that it got controlled. And so in the final outcome, so initially the child was having -10 and -8, and she was improving only to 20/50. Now with the after the surgery with IOL, she is 20/20 with the best corrected visual acuity. IOP is controlled with 2 medications. So this is the importance, like you should intervene at the right time. And many cases, sometimes initially may not be trapped because the lens might be a culprit in these cases. So we need to assess whether that is why I mentioned that gonioscopy need to be done, because some of these cases might have an congenital angle anomaly. So in those cases, and some cases where delayed intervention, where it has already caused a ankle synovial closure, then even after you do a lensectomy, vitrectomy, these kids might require an AGM to be continued or a trap procedure or a glaucoma device later. So it is gonioscopy which is very important. If whenever before intervention, if you can do that, and whenever the lens is the culprit, if you tackle the lens many a times, the IOP might get controlled to a limit where the refractive error has been, like child has been tolerating well. So in many of those kids, you see that after intervention, the visual acuity also improves and the child's quality of life also improves. This is a case too. This is actually siblings. Both of them had subluxation, and both the kids were under follow-up for 5-6 years, and this one of the kid I am presenting. So this over a follow-up of 5-6 years. Now when I saw the kid was like having 636 in the right eye with -10, and the left eye was -14 and improving to 636. And right eye already had a scleral thinning, and AC was very shallow. 1 PA was done at that point of time in both eyes. And when later actually this kid's sister had presented in our OPD with an acute anterior subluxation and angle closure. So that time that kid has to undergo a pars plana lensectomy. So that was the point when this kid was sent to us. So that point of time, because there was a microspherophakia, and I did a pars plana lensectomy, vitrectomy and a flange dial for this kid. So post surgery, his left eye IOP is maintained. His best corrected acuity improved with -2 to 612, and the right eye we can't intervene now because the anterior chamber is completely flat and there is an iridocorneal touch, so it is very difficult to intervene in that eye now, and he is only counting finger close to face. So this is a left eye surgery which we did. So this time I did not do a subscleral flap incision because I was planning for a flange diol in this kit. So 3 separate sclerotomies were made. And actually supranasal here you can see there is already a scleral thinning. So this kid might be a Trabowsi syndrome most likely. We had asked for a genetic screening, but it's a single parent kids actually, so they won't afford all these things. So this is how the flange IOL is being done. And post-op, the child is very happy. In fact, he comes to OPD smiling and very playful. So whether the lensectomy will help in this condition, so already there are published literature. So this study by Divya Rao has shown that lensectomy alone without any IOL, have 50% of the patients the IOP reduction has happened, and even sometimes only 7.7% needed actually any surgical procedure. And this was one of our own publication actually, where we did lensectomy and I did glutathione in for all these kids. But this group was actually having an advanced disease and on maximum medication. So here actually, even in these kids actually, 21% over 1 year could get controlled with the surgical procedure. So surgical outcomes actually is very good, and especially both in terms of control of IOP and also in terms of best corrected visual acuity. So tailoring a vitreoretinal surgery in ectopia lenses like a timely surgical intervention, it saves both like in a long-term complications like glaucoma. Second thing is the refractive error the child is having, but we need to individualize the IOL, which are the surgical procedure which need to be done in this, and a multidisciplinary care like a pediatric ophthalmologist, again because of the systemic issues with a pediatrician and a physician or an orthopedician is required in this. So thank you.
Thank you, Divya, for that wonderful talk. Do you have any problem assessing the IOL power in these children?
So usually if the kid is like less than 7 years, I reduce it from the age actually. So if 5-year-old, like I usually measure it like 7 minus 5, that is 2 diopters I reduce if I take for less than 7 years of age. And that is the only manipulation which I make actually, or sometimes 0.5 less, but usually I don't do that much.
Okay.
If time